I want to welcome you all to the first Masonic Cancer Center seminar of this new academic year. Just one side note, I wanted to remind everybody that the abstract deadline for the fall symposium for the Cancer Center, which will be happening in November, is this coming Friday. So remember to register and submit your abstracts this week. So it's my pleasure to introduce our speaker, who is Professor of Medicine and Director of the Masonic Cancer Center, Dr. Douglas Yee. Dr. Yee received his Bachelor of Science degree in Zoology and Anthropology from the University of Michigan and an MD from the University of Chicago. So he's a Midwestern guy. He holds the John H. Kersey Chair in Cancer Research. He was a Pew Scholar, and he's been named a top doctor by Minneapolis-St. Paul magazine. He's published over 140 papers, and his work really spans the gamut from basic research through to translational research. He's an expert on signaling by insulin-like growth factor receptor in breast cancer, and he's investigated this pathway clinically as well. And today he's going to tell us about the I-SPY neoadjuvant breast cancer study. So welcome, Doug.
Thanks, Dave. Thank you. Thanks for the opportunity to give this talk and to invite me to be the first speaker this year. When they asked me to pick a title, I said, okay, fine, I'll pick a title. and then Aaron was kind enough to make me a hat. So I am not going to wear this hat throughout this talk, but I had to put it on. But, you know, I really wanted to talk about, and this talk is going to be, I think, a little more clinically than we usually have, but I want to talk to you about the future, where clinical trials are going. And I actually want to have this as an opportunity to talk about this particular clinical trial and the potential for anybody in this room to collaborate about what we're doing here. One thing that happened when I sort of made this title, I got sort of the most negative reaction, said, well, you can't be partisan about this. So my alternate title is I'm with clinical trials. And so whatever side you're on, I hope I have you're covered. And I want to tell Jill said I had to do that. So I want to talk about breast cancer and talk a little bit about breast cancer mortality and how it's changed over the course of the year. So this particular graph is from the World Health Organization mortality database. It stretches from the 50s to the present, and you can see that breast cancer mortality in the United Kingdom and the United States had increased over a period of time, and toward the late 80s it had really decreased. This was also seen in other sort of Western European countries. Other countries have lower death rates. This is corrected per 100,000 patients, but a very dramatic decline in mortality. In the U.S., the mortality for breast cancer is as low as it has been since we started recording these statistics. I do want to make one other political comment, and that's the sort of the rise in mortality. The pointer sort of died on me, but we'll figure it out. The rise in mortality in the United Kingdom when the United States stayed flat. My political comment is that was widely attributed to the National Health Service and again, this is not political comment in the context of the National Health Service is bad. This is a comment that when you change the way you deliver health care, you can affect cancer mortality in unexpected ways. So the National Health Service made it very difficult for breast cancer patients to see specialists and subspecialists. And in many respects, they were mismanaged. So that is an important part of cancer mortality, disparities in health care, which I'm not going to talk about today, but it deserves a talk of its own. So this is a slide from Don Barry. The name Don Barry will come up again. He's a biostatistician at the time at MD Anderson and went to try to explain what happened to breast cancer mortality during that time period. So what Don did was he said, well, what happens if we didn't do anything? Breast cancer mortality would have increased. What happens if we started population-wide screening programs only? It would have stayed stable. If we only gave adjuvant therapy, and we'll talk about adjuvant therapy, it would have stayed stable. But the combination of both decreased mortality. So why did we start doing this? Why did we start screening patients for breast cancer? Why did we start giving adjuvant therapy? And we'll explain that to patients. And it really is because of all the clinical trials that were done previously. So historically, I just want to go over a couple of things, and many things you probably know already. I'm not going to talk about mammography. I think one of the raps on mammography is that all of the studies were flawed in their own special way. Collectively, when you put them together, they show a decrease in breast cancer death if women undergo screening mammography. There's a debate about what age do you start, how frequently you do it, but I think that's been the overwhelming message from the screening trials. And mentioned, I think the fact that there is controversy doesn't mean you shouldn't be screened. I think it means you need better actually screening tests, and that's, again, a topic for another discussion. So the other things we've learned is surgeons can't cure breast cancer, and I'll explain that in a minute, too. Breast cancer is a medical disease, and I want to emphasize that even though the surgeons are intimately involved with breast cancer care, as are the radiation oncologists, the thing that drives mortality down is the medical therapy. Basic science translates into improved clinical care. One of the reasons I got interested in breast cancer because there was a first case example of that, and we'll go over that a little bit too. And then finally, knowledge turns take a long time, and I'll explain that's the basis for the I-SPY trial. So first point, surgeons can't cure breast cancer. This is the 20-year follow-up of a trial comparing mastectomy versus lumpectomy and radiation. The original trial, B06, was done in 76 through 84. I was a medical student in somewhere in that era, and I remember very distinctly the senior breast surgeon telling me that this trial was completely unethical. Everybody knows you need a radical mastectomy to cure breast cancer, so we're never going to contribute to this particular study. So that was the prevailing feeling at the time. We've had 100 years of Halstead radical mastectomy. Bernie Fisher, to his credit, took on that particular practice and first reported the results in 1985. So this could be viewed as a negative trial in some respects, but negative trials can be practice changing. What this trial demonstrated was, first of all, radiation with lumpectomy was better than lumpectomy alone. But interestingly, even lumpectomy alone did okay with preventing recurrences. But it didn't really matter to have a more aggressive surgery, that the outcomes for radical mastectomy or simple mastectomy in this case, lumpectomy and radiation were all similar. So you don't change anybody's mortality because you do more radical surgery. The reason women die of breast cancer is because we believe a significant number of women has disseminated disease at time of outcome, at time of presentation. And give credit to the surgeons. They figured this out first. This happens to be the Italian experience, but Gianni Bondadano was a surgeon, and he decided, well, you know, the reason patients are dying is not because I failed to take out the internal mammary lymph nodes. It's because I failed to address systemic spread. So this particular trial was combination chemotherapy. It occurred in the 70s, roughly about the same time as the clinical trials of lesser surgery were being done, but all of these women had a total mastectomy. But 391 patients whose lymph nodes were positive received 12 months of chemotherapy versus nothing. It's amazing to me that women volunteered for this study. CMF is not actually the most benign regimen in the world, and 12 months of CMF, I can't believe anybody got through it. There's an old joke is that this was done largely in Milan, and the Milan sewers were full of Cytoxan because the Cytoxan was given orally. You had to take it for 14 days in a row, and there's been big issues about whether people were actually complying. But nonetheless, this was the trial that was done. Nothing versus CMF, and it showed that systemic therapy cures breast cancer. That's my title. It demonstrates the women who got CMF in the top line, and the bottom line is the women who got nothing. And this was really defined as treatment failure. Treatment failure was a very loose term back when these trials were done, but it meant actually recurrence or death from anything, and it demonstrated that CMF patients, even with the high-risk positive disease, benefited. So that really led to the idea that, well, cure breast cancer is not so surgically oriented, but it's systemic therapy oriented. These initial trials led to a whole slew of additional studies looking at chemotherapy. This is the meta-analysis. The meta-analysis is a publication that comes out roughly every 5 years in the Lancet. It takes a look at all of the clinical trials that were ever done with chemotherapy, randomized clinical trials, chemotherapy versus nothing, one type of chemotherapy versus another type of chemotherapy, and it demonstrates that if you get chemotherapy, And this is identified as breast cancer mortality over years. Your breast cancer mortality is lower if you get chemotherapy than if you get no chemotherapy. And just not to belabor this too much, but the type of chemotherapy, the anthracyclines, might be a little bit more important. There are a lot of things wrong with this figure. You know, the major thing that's wrong with this figure is breast cancer mortality is still pretty substantial. So breast cancer is a common disease, and the absolute benefit of roughly 6.5% means there are many fewer women who are going to die of the disease. But on the other hand, if you take a look at the breast cancer mortality of 30%, it's sort of 15 years, and women who got what we think is the best chemotherapy, that's not great either. So there's a lot of room for improvement. In my view, this particular meta-analysis outlines what all the problems are in breast cancer. First, there's a substantial number of women who didn't get chemotherapy, who never recurred. That's important to know who those are. There's a subset of women, as I mentioned, who got the chemotherapy, who still recurred. And then finally, there's a subgroup of women who really benefited, who, if we could really figure out who those women were in each set, we do a lot better in terms of the way we give treatment. We have, however, went through a period of time where we really thought if we gave more chemotherapy, we would be better off. This is a study from my friend Sandy Swain. Sandy was president of ASCO, and she appointed me as the scientific program director that she was as president. But I don't want to beat this up, Sandy up at all. This was the testable hypothesis. If you gave current chemotherapy, which in this slide is adriamycin, Cytoxan, followed by Taxol, if you give them all at the same time, that's a TAC regimen, or if you give another drug, gemcitabine, in addition to the paclitaxel, would that be better? And the answer was no. So the problem with the study is that's still an important question to answer, but if you take a look at how many women you had to enroll, you had to enroll roughly 5,000 women to come up at the end of a study saying, well, the standard of care is better than the standard is just as good as the experimental arms. And to me, that's not a good outcome either. And we'll address that issue in I-SPY too. I do want to turn to the idea that basic science translates into improved outcomes. This is a paper from my postdoc mentor, Mark Lippmann, published in Nature in 1975. First, he identified a cell line, the MCF7 cell line, which for the breast cancer researchers in this room, we all know and love, as an estrogen receptor positive cell line. And shown in this particular graph, if they did thymidine uptake, you had increased, I'm going to do this pointer. You had increased thymidine uptake if you gave estradiol. If you gave a lot of estradiol, you actually had decreased growth. That we don't talk about that too much, and also you see that with DES. But for a long time, high-dose estradiol and DES were a therapy for breast cancer. It's just unbelievably toxic, and so it really wasn't pursued. However, what he also showed was the drug tamoxifen, which was initially discovered not as an anti-estrogen receptor drug for breast cancer, but as a fertility-inducing drug like clomiphene or Clomid. It's in the same class. It blocks estrogen receptor in premenopausal women and causes disrupts negative feedback through the pituitary and gets women to ovulate. It's just that tamoxifen didn't do it very well, but it did work as an estrogen receptor inhibitor in breast cancer, and it partially induced suppressed physiologic concentrations of estradiol in this experiment. So once that was done, tamoxifen was widely adapted. And I reason we want to show you the tamoxifen experiment is because it also led to the observation that is so obvious now, but was not obvious at the time, is that you had to have the target for the drug to work. So tamoxifen inhibits estrogen receptor by binding the hormone binding domain, a competitive inhibitor for estradiol. And there was a lot of debate when tamoxifen was developed. Was that necessary to determine a response? So these are similar data from the meta-analysis, which demonstrates an estrogen receptor positive disease. You see a substantial decrease in, I think, in this case of recurrence, if you get 5 years of tamoxifen. In contrast, if the disease is estrogen receptor poor, you see no benefit. So that observation really led to the idea that, well, there are biomarkers that predict outcome. For many cancers, even until recently, we treated every cancer like it's the same thing. And breast cancer, it's clear that's not, and that's actually how I got interested in breast cancer, to try to understand how different subsets of breast cancer responded to different therapies. So those are a lot of old trials, and I wanted to just go, so what have you done for me lately in terms of clinical trials? First off, this is not that late. When I got here, we were still doing autologous bone marrow transplant for breast cancer. This was a really bad idea. Not that it wasn't a bad idea, not that it wasn't a testable hypothesis, but we were doing this outside the context of randomized clinical trials. When the randomized clinical trials were finally published, demonstrated autologous bone marrow transplant really had no benefit versus the standard of care. The other thing that's important to recognize is going along the biomarker subset is we identified HER2 as an important first prognostic biomarker and eventually a predictive factor. Predictive factor means that if you have the marker, you will respond to a drug directed against that marker. So we have many HER2-based therapies now that, at least in the course of my career, have changed what were the worst outcome patients to, I'm not going to say favorable outcome, but they have more treatable tumors if you treat them with HER2-based therapy. And that, to me, demonstrated the power of identifying things that cause bad outcomes in cancers and developing a rational clinical strategy against them. The surgeons are also starting to understand they don't even have to sample lymph nodes very much anymore. The field has changed into lymph node sampling and without a full axillary dissection. So back when we were doing radical mastectomy, they used to take the breast, the chest musculature underneath, all the axillary lymph nodes. Major complication was substantial lifelong lymphedema, and when the surgeons started doing lumpectomies, they still dissected the axilla, and that still resulted in lymphedema. So the surgeons figured out, well, let's not do that anymore. Let's just take 1 or 2 lymph nodes. And they do that, and even if they're positive, they don't have to take out the rest of the lymph nodes. They can just radiate the armpit, and lymphedema and quality of life is much better. So that, in some ways, it could be construed as a negative clinical trial, but the surgeons are moving down the pathway to, well, let's do less and less surgery. Let's try to get away from very morbid procedures. And then finally, this is not necessarily a clinical trial result, but I think we are identifying that many promising drugs and targets are emerging, and we also understand that the benefit of the drug, just as we do for tamoxifen and the HER2-based therapies, are dependent on the molecular subtype. I think everybody has seen a version of this. This is adapted from Chuck Peru's original observation. Chuck Peru used the old spotted glass array, where basically just looked at gene expression profiling across breast cancers and find out they were very heterogeneous in terms of what they were, although they could be grouped with supervised clustering. For those of you that don't see this all the time, the line down is a tumor, and the line across is a gene. And we classify in this very simple sort of analysis into just a couple of basic subsets. When we first saw this, or when I personally first saw this, everybody said, yeah, we kind of knew that, didn't we? So we knew there were ER-positive breast cancer patients, those that responded to estrogens that we call luminal A, those that didn't respond very well that we call luminal B. We understood there was HER2 gene amplification in the HER2-driven tumors, and we understand they're basal-like tumors as well, which we kind of sometimes shorthand as triple-negative breast cancer, which is not a very good term in my view because it's positive for something. It just, triple-negative breast cancer just displays our ignorance in figuring out what is driving those tumors. But on the other hand, it helped molecularly classify things, and the thing that I'd like to point out is sometimes a molecular classification is better than your clinical intuition about what's happening. And I'll try to show an example or two of that. So what we've learned from clinical trials in the past is a very heterogeneous disease. We've now learned one-size-fits-all clinical trials are not going to yield high-impact results. I don't think we can, and in some ways this has led to a dearth of new clinical trials in breast cancer because it's hard to molecularly subtype breast cancers and then give the particular therapy necessary to treat that molecular subtype. I'd argue it's becoming an orphan disease. We're getting smaller and smaller subgroups. So let's just make up a story. When Jennifer Pintenpole was here, she talked about basal-like breast cancers, the very small subset that had evidence of EGF receptor gene activation. That's a tiny fraction of those triple-negative all breast cancers, even a smaller fraction of basal-like breast cancers. And it's hard to do clinical trials in that setting. And but it's going to require us some work, and I-SPY 2, I think, helps address that a little bit. The speed of discovery of cancer targets, thanks to all the great basic science, really exceeds our ability to validate targets in clinical trials. And that's where the roadblock is. We throw out a lot of drugs that might be good. We continue to work on drugs that have only a small level of benefit. And I think I would argue that we invest in basic translational cancer research really requires a change in the investment in clinical trial conduct. I don't know if everybody saw the official Blue Ribbon Panel of Moonshot publications. You take a look at it. A very big emphasis is on clinical trial conduct. You know, the current statistic in this country is that less than 5% of eligible patients participate in studies. That holds back progress. And a big feature of the Moonshot is to try to increase the participation. So that's kind of the big background. And I think I-SPY 2 got started partially because of an observation that the late Andy Grove made over 10 years ago now. So as you know, Andy Grove was one of the founders of Intel. And in their business, they define things as a knowledge churn. So a knowledge churn is going from a hypothesis to a discovery to a change in practice. And I think, as you know, in the semiconductor business, that occurs every couple of months. So when you're going to buy your iPhone 7 soon, if you don't get an iPhone 8 in a year, you are going to be very disappointed. In breast cancer, so that's a knowledge churn, hypothesis, result, new hypothesis, new result. In breast cancer, it's taken a really long time to go from showing advances in metastatic breast cancer to changes in adjuvant therapy, to change in practice. It can be at least 20 years or even more. I'm going to argue that if we give our chemotherapy or experimental therapy earlier, we can decrease that knowledge churn in 2 to 3 years. So if we give our therapy in a neoadjuvant setting, and then we move to a phase 3, we can change practice in a very short period of time. And that's what I-SPY 2 is about. And I know that most of you don't think about neoadjuvant therapy or what it is. So neoadjuvant therapy is really giving the chemotherapy before women go to surgery. So going back to the surgeon, when they figured out that surgery was not that important in providing overall survival, but chemotherapy was, they did a series of trials where they gave the chemotherapy first, surgery, or they gave the surgery first, chemotherapy afterwards. That particular set of trials showed it didn't matter. You had to get the chemotherapy, but that couple-week interval of surgery didn't make a whole lot of difference in terms of disease-free survival or overall survival. However, the one thing they did observe, if you leave the breast cancer in place and you give treatment, some of them will completely disappear under the microscope. We call that a pathologic complete response. And also it seems like a no-brainer that if a woman has a pathologic complete response to the chemotherapy, they're going to have better outcomes than they would if they had lots of tumor left after the chemotherapy. We have to go with the idea that the breast cancer is a surrogate marker for any disseminated micrometastatic disease, but that's been the working hypothesis. And the working hypothesis is shown by the data. These are data from one of the older neoadjuvant trials from the National Surgical Breast Involved Project. The little black dots are pathologic complete response. The little, everything else, this is pathological invasive disease present in the resected specimen. This is clinical partial response, clinical no response. If you look at overall survival, disease-free survival, and relapse-free survival, you find that it's always good to have complete disappearance of your tumor prior to treatment. And it correlates with the things that were important to us, and that is improved overall survival. The FDA sort of commissioned a larger study with all the neoadjuvant trials that have been reported. And the reason they did this is because the FDA was looking towards approving drugs in the neoadjuvant setting. In other words, the FDA said, well, if your drug in combination with chemotherapy increases the pathologic complete response rate, we, the FDA, can see a way to giving your drug rapid approval. And they needed to understand how robust that relationship was. So they did a meta-analysis, and they showed that there was a relationship, that the event-free survival and overall survival were improved if you had pathologic complete response. So they're willing to accept pathological response as a surrogate marker. The one problem with pathologic complete response is its meaning is different depending on the subtype of breast cancer you have. This is a model that Don Barry put together and reported with Cliff Hudis. So I want to try to explain this to you. This is the increase in pathologic complete response rate. In other words, if drug A gives you 0 pathologic complete response and drug B gives you 100% pathologic complete response, what happens to the event-free survival rate? So in this example of triple-negative breast cancer, you decrease the hazard ratio by about 75%. In other words, it's not perfect. If you have pathologic complete response, your mortality is not 0. If you have no pathologic complete response, your overall survival is not 100%, or vice versa. But there is a good relationship, and the other aspect is the relationship depends on what type of breast cancer you have. So this is HER2-positive breast cancer. This is triple-negative. They did not model estrogen receptor-positive breast cancer, but estrogen receptor-positive breast cancer is the least likely to have the graph would look something like this. It's always good to have a pathological complete response, but it is not a very good predictor. This particular editorial was written based on the controversy around the neoadjuvant HER2-based therapy, and basically what they showed, the increment to adding this extra drug was not sufficient to really move us very far down the curve. So the advances had to be pretty big. So just to summarize neoadjuvant therapy, it's patients treated with the chemotherapy for surgery. Patients with a pathologic complete response rates have better outcomes, and the value of pathologic complete response depends on subtype. So this comes from the FDA's meta-analysis. It shows you HER2-positive disease and triple-negative disease in HER2, showing that the pathologic complete response is a little bit less meaningful in hormone receptor-positive disease. In contrast, if you have a pathologic complete response, it's still a good thing. The good part about this, in terms of our knowledge terms, is we can get this information in 12 to 24 weeks. So if we do a standard adjuvant trial, where we take out the breast cancer, we give a therapy versus another, we have to wait until there are a number of events. That can spread out from 2 to 5 to 10 years before a trial is ever reported. As I showed you with Dr. Swain's study of gemcitabine, sometimes it's so late in reporting, the field has moved on, and the initial question is not that interesting anymore. The pass CR rate, though, you can get it very rapidly and hopefully get the information out much sooner. I'd like to talk about the I-SPY 2 trial. The principal investigator of I-SPY 2 is Laura Esserman. Laura is a surgeon at UCSF. Laura spent many hours torturing this acronym to come out with I-SPY 2. But it really is serial studies to predict therapeutic response with imaging and molecular analysis. It is now an international study. These are the 16 sites that are open to accrual. The reason it's international is a Canadian site has come on board. We have it open, as does the Mayo Clinic. Where we are in terms of this trial is it's as of last month. We've randomized about 1,000 patients on the study, and we've completed surgery in about 850. I'll just show you this because we accrue pretty well to this trial. We've been open since 2010. The goal is to enroll 1 a month. We're just a little bit under that. I should comment UCSF and UCSD accrue like crazy because they're associated with community hospitals that are their county hospitals where women present with bigger breast cancers and there are many more. They see many more patients who are eligible. But we do pretty well with our patient population. One of my goals in life is to stay ahead of Mayo's accrual, which we have been, and we're going to try to keep working that direction. So let's see. My computer's thinking about whether it wants to show you the next slide or not. This is the design of the trial. So it is a complicated trial. I do at the end acknowledge everybody who's involved in this trial. So when patients come with a new diagnosis of breast cancer, and it's almost always about mammography or women feel their own breast cancers and they have to be big enough, they are consented. They're consented for a research MRI. They're consented for a research blood draw and biopsy. And we do the MammoPrint assay. So the MammoPrint assay is an older gene expression profiling platform that Affymetrix owns. It's on essentially an array type expression profile. For those of you that are doing omic analysis, you know that that's not sort of the state of the art, But the reason we picked it is because at the time I-SPY 2 opened, it was an FDA-approved device. And our view of the world was that if we're going to make clinical decisions on any omic platform, it has to be FDA-approved, and that's how we picked it. So when we get the biopsies, we send them off to UCSF. They run the assay. They report back. If a patient is then eligible, there's a second consent form where a patient gets treatment. They get treatment with Taxol alone, followed by Adriamycin and chemotherapy, or Taxol with a variety of experimental agents. This occurs over 12 weeks. There's another MRI and biopsy at 3 weeks into the trial, so after the first round of exposure to the investigational agent. There's another MRI at the end of 12 weeks of experimental therapy. There's another MRI before surgery, and if there's any tissue left at surgery, that's available too. So I think, to me, one of the big appeals about I-SPY 2, it gives you three things. It gives you, one, the predictive biomarkers up front. Secondly, it gives you an immediate response, ability to measure immediate response to the tumor and experimental therapy. And then finally, if there's residual tumor at the time of surgery, it gives you information about resistance. So there aren't that many diseases where you can do this. Breast cancer is one that is amenable to lots of different biopsies over time. And fortunately, women who participate in this trial have not had a huge issue with a couple of research biopsies as part of the procedure. We also look at research MRIs because they are functional biomarkers of response as well, and I'll show you an example. So one of my jobs, my job on this trial is I'm the chair of the agent selection committee. So my job is to be the liaison between companies who might be interested in participating in I-SPY 2. These are the drugs that we've had through the study. So a couple things, and I want to give Laura Esserman credit for this. Laura has made it such that our study is completely agnostic to the biopharmaceutical partner. So you can have a Merck drug, an Amgen drug, a Pfizer drug. The partners don't actually care that their drug is in a trial with a bunch of other drugs because we're examining their drug against control. So we're not examining the PARP inhibitor against the EGF receptor antagonist. Their drug is going against control, and they're interested in how it performs in that way. Again, the ones in blue have graduated from the trial, and I'll explain to you what that is. The ones in sort of purple, Ganitumumab and Ganatespib, have graduated from the trial, but I can't tell you about them because they're embargoed until San Antonio in December. As much as I'd like to tell you about the IGF receptor inhibitor, because that's what we work on, I'll tell you it needs more work. And then finally, the couple of drugs that are in the trial now, pembrolizumab, the PD-1 inhibitor, a PARP inhibitor with irinotecan instead of a Taxol platform, and that's based on the preclinical data that was obtained by the company, and a HER3-based antibody. So multiple drugs through multiple times, just in terms of efficiency. Every time a new drug enters a trial, we don't have to go through opening a whole new trial. We just drop in an amendment. It kind of rolls through all the regulatory pieces, and it's easy to put a trial in. So how do we do this? We do this with women that have tumors that are greater than 2.5 centimeters. They have then analyzed the important clinical aspects of their tumor. So they can be hormone receptor positive, ER or PR, or hormone receptor negative. They can be HER2 positive or HER2 negative, or they can be mammoprint low risk, and that's the gene expression profile, or mammoprint high risk. We made a decision early on in the trial not to include hormone receptor positive patients who are mammoprint low risk because at the time we felt it was not technically ethical or warranted to expose those women to chemotherapy, much less an experimental agent. Just wanted to digress for a second on the mammoprints. So this was published just a couple of weeks ago. This is the 70-gene assay, the Dutch the thing we call the mammoprint or the Dutch assay in New England Journal of Medicine, where this was largely done in Europe between 2007 and 2011. They screened 11,000 patients and 6,000 patients were enrolled. The principle of this trial was to look at genomic risk compared to clinical risk. So if a patient had a tumor, it was biopsied. Physicians made an assessment of clinical risk with a tool called Adjuvant Online, and the mammoprint came back. The mammoprint comes back as dichotomous. Either it's high risk or it's low risk. And patients who had high risk were all assigned to treatment. Patients who were low risk were all assigned hormone therapy if they were estrogen receptor positive. People who were discordant were randomized either to chemotherapy or hormone therapy. And the punchline was, it really doesn't make a difference if you're, whatever low risk you are, you're low risk. If you're genomic low risk, if you're clinical low risk, you really don't benefit from chemotherapy. This is a tool we're going to have to work through. It kind of goes a little bit counter to what a lot of people believed, because if you were clinical risk and genomic high risk, we would have thought that you might have needed chemotherapy, but that's not what the clinical trial showed. And I just wanted to use this as a demonstration of why we're using the MammoPrint within the study, because at least it's a validated tool in the randomized clinical trial that's been recently reported. So the other aspect of I-SPY 2 that I think is novel is that it's an adaptive design. This is a design that Don Barry has pushed very hard. So the idea is that in the beginning, everybody has the same randomization probabilities to a drug. We calculate the success probability for each signature, and I'll explain the signatures in a minute. If they graduate or futility met, the answer is no. And the randomization can be revised within each subtype, and the trial will continue. If you reach graduation or futility, then you'll stop. So during the course of this trial, if it looks like the benefit of drug, because we get immediate readout of pathologic complete response, the randomization will change. So let's suppose the drug is only good in a triple negative subset, because the last X number of patients showed that all the pathologic complete responses were in the triple negative subset. The next patient that wanders through the door with a triple negative subset will be assigned that drug because the randomization changed. It's no longer 50-50 randomization, or if there are 8 drugs in the trial, it's not divided by 8. You will get assigned to the drug that you should benefit from. That's one of the things I like about the trial, too, because when I said breast cancer has become an orphan disease, it's getting very hard to split trials down. So if you said, well, I only want tumors that are BRCA-like, and I'm going to do the neoadjuvant trial in that set, it's going to take you forever to do that trial. In contrast, if you adjust the randomization as you're doing the trial, you get to the answer much sooner. So that's the basic design, and then we can drop in new drugs as drugs leave the trial. So I don't think I-SPY 2 will ever end until no one has breast cancer mortality anymore. At least that's the way I'm thinking about it, because there will always be new drugs. You know, we would not have proposed pembrolizumab 6 years ago when we opened the trial, but now that it's available to us, we can drop it in the trial. So I want to show you, so we've just reported about a month ago the first 2 drugs, Nerantinib in HER2-positive disease and Veliparib carboplatin in the neoadjuvant setting. These were in the same issue. If you're interested in this topic, there was a very nice perspective written by some colleagues in pharmacology about the adaptive randomization, and there was another article written by Lisa Carey and Cliff Hudis about whether or not this changes practice. And I'd say right off, it doesn't change practice today, but I think it really changes the way we do clinical trial designs. So I want to spend a little bit of time on the Veliparib carboplatin, and I want to spend a little bit of time in detail. If you were here for Alan Ashworth's talk, you saw this slide. You understand there are synthetic lethal strategies based on DNA repair pathways. The BRCA-like patients have defects in double-stranded DNA breaks. The PARP inhibitors were designed to inhibit base excision repair. And the principle was if you were already deficient in homologous recombination, you then inhibit base excision repair. That's a synthetic lethal strategy. And Alan did a beautiful job of demonstrating that particular pathway. So just to comment, I mentioned we have another PARP inhibitor in the trial. It is in combination with irinotecan to block other pathways that could combine with a PARP inhibitor. But I want to tell you about a patient I saw a couple of years ago now. She's one of the earlier patients on the trial. She's 41. She noticed the right breast mass. In August, it identified that she had a 4-centimeter mass. She had a biopsy. It was an invasive ductal cancer. It was ER/PR and HER2 negative. She otherwise was very healthy. She's an occasional exertional asthma. She's very physically active. She's a competitive bicyclist. I'm not disclosing any HIPAA private information. She actually is a faculty member at the university, and she did a piece on CARE 11 outlining why she participated in the study. So this was her MRI. You guys are probably not used to looking at breast MRIs, but this is her breast mass. This is her chest wall. This is her heart. So this is a pretty decent-sized breast mass. After she got her 12 weeks of paclitaxel, carboplatin, and veliparib, you would argue that it couldn't be seen. She had a very rapid and what appeared to be a clinical complete response. She finished her chemotherapy. She went on the surgery. She had a bilateral mastectomy. That was her option. She could have had a lumpectomy, but she preferred a bilateral mastectomy. She had no invasive cancer in her breast or sentinel lymph node, and her residual cancer burden was 0. We have a scoring system of 0 to 4. It turns out 1 is not so bad. If you have some scattered islets of residual invasive cancer, that's not so bad either, but hers was absolutely 0. So that was a good result for her. This is the result for the group, and I want to take you through this just to make sure you understand what we're trying to do. So veliparib is a drug. It's ABT888. It's not the most potent PARP. This is an old slide. Not the most potent PARP inhibitor, but it is a PARP inhibitor. For this analysis, patients were adaptively randomized to receive veliparib carbo, paclitaxel versus paclitaxel. It was only open to patients with HER2 negative disease. Not because we don't think HER2 positive disease couldn't benefit from PARP inhibition, but it's because we didn't have safety data that you can combine it with an anti-HER2 therapy. So it's part of my job on the agent committee is to make sure that if we're going to open an arm, we have appropriate safety data. The last thing we want to do is put an experimental agent in the trial that precludes the woman from getting her conventional therapy because these women have potentially curable disease, and we don't want to miss that opportunity. And I will say we actually have had one drug we had to drop out of for toxicity that was unexpected, substantial transaminitis and hyperbilirubinemia, that after we saw 2 patients with the same phenotype, we just said we can't use this drug. So at any rate, that's the trial design, and you've seen how we did it in the previous slide. So I want to go over the biomarker signatures. So there are 8 biomarker subtypes in these boxes. So there are 8 boxes, but there are 10 marketable, I don't know why we use that term, but we use the term largely for the sponsors of the drug to know where their drug would work. And this gives you a distribution. And so the 10, I'll go over exactly the 10 trials. This is sort of the distribution of the 10 market signatures that we see on this particular study. And these are the percentage of patients who've been enrolled to each one. So let me just buzz through the 10. They could be, a drug could work for everybody. So that's 1. The drug could work only for hormone receptor positive subgroups. The drug could work for only hormone receptor negative subgroups. The drug could work for only HER2 positive. It could work for only HER2 negative. It could work for the high mammoprint scores. So these we called ultra high because everybody already had a high score. It could work for the triple negative subgroup that are neither hormone receptor positive or HER2 positive. It could work for the hormone receptor positive HER2 negative subgroup. It could work for HER2 positive hormone receptor negative, or what we call the triple positive subgroup. Those are the ERPR and HER2 positive. And I think that's 10. But I wanted to go through those because there's more than 10. You know there's more than 10. Because some of those groups that I defined, let's pick this one, hormone receptor positive, HER2 positive. Some of those tumors are much more luminal A. Some of those tumors are much more HER2 driven. But in the context of practicality for a clinical trial, it's really hard to do that and make those decision lines so fine. So let's take a look at what the results were for the veliparib carbo arm. So first, 75 patients were randomized. 46 patients had concurrent control. So the randomization engine changed sometime during the study. It's obviously not a 50-50 randomization. There were 18 HER2 positive patients that were concurrently seen at the time this drug was in trial. They were not randomized. We included that statistic to let you know what would happen. So, and here's the distribution of patients that were randomized. Again, the HER2 positive patients did not get the drug. when we do estimations of pathologic complete response, Don Berry makes it very clear to say these are estimations because it's not a randomized trial in the way you think about it. There are point estimates that have a distribution. So ideally, this would be the control, this would be the agent, and then we report out what the estimated pass CR rate is. So for this drug, for the triple negative subgroup, this is what the data look like. The control versus veliparib carbo, the estimated pass CR rate in control was 26%, chemotherapy alone, 52% in the drug. The probability that the combination is better than control was 99%. The other statistic we have powered this on, and this is a funny statistic, and it's hard to explain to people, but we did it for a practical reason, and that's to predict the probability of success in a phase 3 trial involving 300 patients. We did that because we really wanted to make sure that when our sponsors entered the trial, the owners of the drug entered the trial, they understood how good their drug was in a modest-sized clinical trial that they could do relatively rapidly. We could have picked the N equals 500, we could have picked the N equals 1,000, we could have picked 5,000, but 300 was a number that we all felt was reasonably comfortable for us. So if you look at all the patients, the chances that it was better than control was true, but the fact that it wasn't going to work in a during a phase trial, maybe it would work in 1,000 trial, but that particular side, there was predicted probability was low. If you looked at the hormone receptor positive subgroup, first off, the estimated pass CR rates are very low, and the chance of it being a benefit is not in its favor. In contrast, HER2 negative, hormone receptor negative, there's a 90% chance that this is positive in a phase 3 trial. So the company that owns this drug, AbbVie, is doing this trial. So I think it's actually almost closed. The phase 3 trial is almost done, and we'll see if we were right. But I do think if we go from start to finish, and it turns out adding PARP inhibitor to carboplatin in the neoadjuvant setting for triple negative breast cancer is better than conventional chemotherapy, I think will have contributed. The other thing I want to comment on is we can measure lots of things in the biomarker analysis. So everybody asked us how many patients you had in this trial were BRCA mutant. And we didn't actually know because the way most patients enter a trial, when they have a diagnosis of breast cancer, very few patients know their BRCA status. Many people have that discovered in the course of the trial, but we had specimens, so we went back into the genomic analysis, and you see in the kind of purple columns the BRCA mutation rate, the PARP I7 signature, which is a surrogate signature, and a BRCA-NIS signature. And it really identifies in this particular diagram that a significant number of patients had the signature, and in fact, 77 patients were predicted to have a DNA repair signature, and that was most of the patients who responded. But importantly, a small percentage of the hormone receptor positive HER2 negative patients also had the signature, along with almost all the triple negative patients. So the drug didn't graduate in that hormone receptor patient because we didn't study the right subgroup in that hormone receptor positive patient. This is obviously a post hoc analysis that tells you where we need to go in terms of our designing trials. I want to show you one more result for a drug that didn't quite graduate, and this is AMG 386 or trebatinib. It's a peptibody to angiopoietin 1 and 2. So angiopoietin 1 and 2, in addition to VEGF receptor, are important in angiogenesis. This is a little particular pathway it binds. It activates TIE2, and the trebatinib, I believe, is the extracellular domain of the receptor fused to a FC domain, and that's why it's called a peptibody. So Amgen had that drug in trial, and this was the results of the trial. And now I say it's close but not quite, because this is a result we actually didn't anticipate. And the result we didn't anticipate that it might have graduated in more than one subgroup. So the good thing about AMG 386, it was open to everybody. They already had HER2 safety data with trastuzumab, so we included the trastuzumab regimen subgroup. So if you look at the overall pass CR rate, you really don't see a lot there, and there was not a predicted probability of success that met our threshold. However, if you looked at the HER2 positive subgroup, not many patients were enrolled, but I think it was not that far off from graduating from that subgroup, and it was not that far off from graduating from a triple negative subgroup. So the fact that this Tie2 antagonist, this angiogenesis inhibitor, might have had activity in more than one subgroup was something we actually didn't anticipate. So we closed the trial because it reached a threshold of accrual where it wasn't clearly going to graduate in an analysis, but in retrospect, we wanted to extend the HER2 subgroup. So just one of the things that drives me nuts about drug companies is we talked about this with Amgen till our faces turned blue, and they just don't want to do the extension trials in the HER2 positive subgroup, which I think is a shame because we still haven't cured all HER2 positive patients yet either. So a couple lessons we've learned from I-SPY 2 is that new drugs may only benefit a specific subset of patients with a disease we call breast cancer. And I hope I made an argument to you guys that we even need finer distinction on a subtype for the 10 signatures. I think a lot of people were in the room that know the breast cancer and they're working on ER-positive disease. They know it's not just two subsets of ER-positive disease. There are probably many subsets. And for sure, as Dr. Pitenpole suggested when she was here, triple-negative breast cancer is subdivided in many, many different subtypes. Rapid assessment of the targeted therapies may speed drug development. As I mentioned, the FDA is interested in this pathway. They have approved one drug in that setting. It's a drug, Perjeta or pertuzumab in the neoadjuvant setting. And hopefully the ADAPT trial design will reduce the number of patients exposed to ineffective agents, provide clinical data, conduct phase 3 registration trials. And I'm really concerned now pushing the biomarkers into the adaptive design. So the biomarkers we have are pretty clinically derived, and I think we need to move through that. But we're going to have that as an active discussion. So what else are we doing in I-SPY 2? My last couple of slides is, can we rapidly identify recurrences that change outcome? And this is a surmount study, and I'll explain what I mean by that. But one of the paradoxes of breast cancer is when patients have clinically evident metastatic disease, that's an incurable disease. On the other hand, I've suggested to you that if we give medical therapy in a setting where women have operable disease, we cure some women of their micrometastatic disease. So there is some line that a tumor burden crosses where suddenly you have grossly metastatic disease where it's no longer curable versus you only have a little bit of micrometastatic disease and it might be curable. And I'll explain where surmount fits that. We're actively arguing different platforms. I'm pushing very hard to get away from chemotherapy in a hormone receptor positive subgroup. For those of you that follow clinical breast cancer, you know we have a lot of different strategies now to inhibit ER function, and I'd like to move those forward. Do immune-based therapies need chemotherapy? That's an active question I'd like to bring forward. And do patients need paclitaxel? And then finally, can we identify patients who are not benefiting from their therapy? And I'll show you a slide on that. But first, just to show you the surmount study from what we're doing. So when I said to you, one of the things I want to do and speak to this group is tell you about some research opportunities. The other thing I do in the trial is I'm on the Data Access and Publication Committee. The Data Access Committee means that if you have an idea, you want to test an I-SPY 2, you fill out a form, the committee talks about it and says yes or no. If you're interested in that, we can have a more discussion about what's really meant. But all of the trials in I-SPY 2 are open for that. This is a surmount study that we have started. Patients will have their neoadjuvant therapy, and their pre-eligibility requirements is they have tumor, they're available, they got their chemotherapy, they had surgery, and they're willing to undergo a bone marrow aspirate. So at the time of surgery, we look at how much tumor is left in the breast. We do a bone marrow aspirate. So bone marrow aspirates have commonly been the only technique for looking at disseminated tumor cells, different from circulating tumor cells. So our German colleagues have shown that a high number of women surprisingly have cells in their bone marrow at the time of presentation or even after neoadjuvant chemotherapy. At present, we don't know exactly what that means, and this surmount is really a categorizing recurrences. And blood for circulating tumor cells. We're having an ongoing discussion of circulating DNA or exosomes or other things, but they can be adapted in the trial design. And then every year we continue to measure them for relapse-free survival. So when I said to you that I'd like to be able to pick up recurrence early and make clinical impact, the kind of standard of care now is we don't do that, but that must be wrong at some level. It must be wrong that there are patients with residual disease that have very minimal residual disease that we can pick up new technology, that we should act on that. So last slide I want to show you is the I-SPY, what we're calling 2 plus PO1. I know it's a complicated slide, but it really addresses a subset of women who had an inadequate response to their first therapy. So I showed you the good stories about people who have pathologic complete response, but you could hold my feet to the fire and say, well, there's got a lot more women who don't have a pathologic complete response. So that's the principle between the PO1 patients. This is the I-SPY 2 trial design, and we're calling this virtual PCR. So the patient I showed you probably had clearly a PCR at the end of her 12 weeks. We're doing that with MRI at the moment, and we're trying to develop a tool in one of the projects to make sure that that MRI reading is robust. The patients then go on to get 2 more cycles of chemotherapy, and if it's clear that they're not responding, we're going to call this a non-virtual PCR. They're going to drop out of the trial. So this is my project. My project is designed to use the genomic information obtained at this point and adapt to a second chance of different therapy. So for example, if we enrolled a patient and they got a PARP inhibitor, and they were clearly not going to have a pathologic complete response, and we go back and looked at their biopsy data and said, you know, they had immune signature. Their immune signature was on, we gave them the wrong drug. We have a chance to adapt here and give them a different immune signature. If you got a hormone receptor positive patient who was having a poor response, you identify the fact, well, they've really got an activated PI3 kinase signaling pathway. We'll drop the drug in there, and ideally we'll continue to go around until the patient achieves a pathologic complete response. So that's where we want to go in the future. We want to really be adaptive and adapt with interpatient as opposed to just the patient population. So that's where we're going in the future. I really do think the neoadjuvant trial design will lead us to answers much quicker and I think be scientifically more robust as well when we make those decisions. So I want to show you my last slide is acknowledgments. If it changes. I have to wait for the program to respond. But I'll tell you, at least acknowledgments on our side. It is a very complicated trial to do, and I'm completely dependent on all my colleagues who take care of breast cancer. There they are outside on our side, particularly the radiologists. So the radiologists, for those of you who don't know who treat breast cancer, control the flow of the way patients go. The radiologists have been very strong, Mike, Tim, and Jessica, in telling us when a patient is eligible for I-SPY 2. We have collaboration with our surgeons, all of our medical oncologists enrolling on trial. Pathology is critical. Molly is the current pathology. Aveen was our former pathologist who called the pathologic complete responses. And this is an incredibly regulatory burden on the clinical trials office. I want to give credit to the CTO. I didn't show you the good slides. We're all up to date on all of our submissions and all of our forms because Gary, Hannah, Ann, and Amy keep us on board in getting all that done. The national trial design, I just want to mention, these are all the committees and their various chairs. As I mentioned, I didn't put myself on there as chair of the aging committee. But if there's anything you want from this trial, if you have a hypothesis you think you could test with an I-SPY 2, that's what we want to do, and we're more than happy to have specimen available for you or even data available for you if you want. So, for example, Todd Tuttle is wants to put together a trial where he wants to look at whether women are more or less satisfied with their surgical decision if they got neoadjuvant therapy or not. There's certainly no reason in the world he can't use the database to contact those patients and do sort of the questionnaire study. So at any rate, happy to take any questions, and thanks for your attention. Brian.
In case of the new I-SPY, what genomic data are you collecting? I mean, you're doing the MammaPrint, but are you also collecting any exome, whole RNA-seq data on these samples?
We have the ability to do that. We haven't settled on a platform. So I'll go back to something I said about a MammaPrint. We need something that's going to meet the FDA criteria for a change in a clinical decision. So you know that probably better than I do. The FDA is reasonably strict about that. And so that's why we've stuck with MammaPrint. But for exploratory studies, everything else is available. We're doing what I didn't mention and I think it's one of the more illuminating things, is Chip Petricoin is doing the reverse phase protein arrays, and in many respects, the signaling agents, that's where the data are. It's not in the omics. It's in what signaling pathways are activated and what has been suppressed.
Other questions for Doug? So I had one about a general thought about I-SPY. So it's hard to argue with the prior observations that pathological complete response correlated with long-term outcome in response to standard chemo that was tested at the time. But now, new basic research is suggesting that tumors are very heterogeneous. Metastatic subclone could be very different than the primary tumor, which is what you're asking. You know, do these new agents shrink the primary tumor better or not? But you could imagine a therapy that would work on the primary tumor but does nothing to the metastatic disease.
Absolutely.
In particular, an agent like the angiogenesis inhibitor, the TIE2 inhibitor you mentioned. So, you know, is there some concern that some drugs would get graduated to phase 3 trial and then they'll fail?
In the event-free survival and overall survival. Yeah, no, I think that that's an absolute, we're absolutely concerned about that. And the critics of I-SPY, too, have really brought that out. And with the different mechanisms of action of the drugs, you may not see, PAT-CR may not be a very good surrogate endpoint. But I guess our view has been the aggregate data suggests that's true, but your argument that with specific agents that may not be true, the angiogenesis inhibitors are a perfect example. So bevacizumab did increase PAT-CR, but didn't seem to actually do anything for overall survival or event-free survival.
Other questions for Doug? All right, if not,
Okay.
thanks a lot.